First, thank you all coming here. Dear faculty and the participants, I think you may not realize, but in my opinion, you're making the history. Because this is the first time ever a conference under this topic is going to be covered. We're going to investigate the sex hormones and its role on endometriosis, more importantly, breast and ovary. This is Breast Cancer Awareness Month, and I'm happy that our little cause in the radar of healthcare is reaching out to acknowledge for Research Alliance. Today you're going to hear wonderful, brilliant speakers who are scientists. They're not like me, I'm just a technician, who are true scientists who are going to look at the molecular and all these things that we fail to understand, they're going to make us understand. And at the end of this think tank meeting, maybe there will be something for future. I just want to start with, obviously, the foundation is almost 10 years old. We're getting there. We are here to promote education, awareness, and push for quality surgical care and treatment and medical care of endometriosis. And historically, why are we doing this? Because we were doing this. We started this as medical conferences in 2010. This was our first conference, which touched the subject of stem cells to radical excision surgery. And stem cells and excision surgery is the key that really opens up the door of understanding endometriosis, because endometriosis is, like, in many ways, surgically challenging disease that needs to be removed. We thought with this meeting we could emphasize that. What you see, that little thing, bubbles under bubbles moving, are new blood vessels popping out like flowers, like seeds. Most likely endometriosis lesion. We have biopsies that they show at least stroma, I promise you. Stroma is there. The top is my animation of, I tried this 10 years ago, I still use it, but I'm not going to go through it. It's a long animation. Basically what it does is constant peritoneal irritation with the blood finally opens up mesothelial cells and activates chronic wound healing that is estrogen sensitive. And we don't know really, it's the implantation from above or from these new vessels these endometriosis develops. Nobody was able to solve that problem. But more research supports definitely there is retrograde bleeding that triggers the event. It's not everything, not at all. We don't understand why certain lesions really go forward and become a massive disaster for the patient. Then we did very brave meeting. We said, let's talk about sex and endometriosis seriously. This was 2011. We want to really go over and run down the barriers, taboo barriers. We want to talk about why the deep disease is never appreciated. We covered a lot of deep disease that year. We talked about deep excision of rectovaginal septum, bowel disease in the cul-de-sac. Then we said, this disease starts at childhood. It's with menarche, maybe with telarche. And we covered the adolescent endometriosis 2012. We got a little bit politically focused. In 2013, we covered politics, controversies. We pushed for endometriosis and other women's problems are all for human rights issue, maybe civil rights issue. We're forgetting about civil human rights nowadays, but definitely in this country, it is a civil rights issue as far as healthcare is concerned. Then we focused on, again, back to early years. We said the head of the presentation, what does it say there? It starts in the beginning. Treatment starts at age. Again, we focused on the value of early diagnosis, early recognition, and removal of the disease. Again, finally, last year, we focused on the surgeon, how important to focus on precision and how surgeons of this disease should be teamed up in order to get the best care for the patient. And every meeting, we did have Patient Awareness Day. We answered their questions in our capacity. And we were grateful that some recognized faces were always behind us. Really acknowledge their help throughout the years. They have been incredibly supportive for us. Well, I can't pass this. Everything in life is a little personal. I lost 2 good friends of mine. They both died of breast cancer within last year. One of them also had advanced stage endometriosis. Their confidential information is still alive in me, so we're going to move. But it is my personal experience starts with Buffalo. Almost 40 years ago, I kind of dropped in Buffalo from nowhere and find this second-year surgical residency program. Having had some surgical experience back home, I started breast cancer clinic in Buffalo. That's how my introduction to breast was initiated. This was an incredible experience for me because this is where I saw radical mastectomies that most of you may not know, except maybe there's one senior surgeon here, he may remember, Halstead procedure where they remove the bone and every little thing until the pericardium. In this case, the incision is on the right side, but I have seen cases, I swear, where the incision was on the left side. You can see the heart pumping like on the chest wall. That was Halstead. In Buffalo, I see fantastic things. I learned the term excision, what it really meant. I learned about scientists from Pittsburgh, Fisher studies that really started the chemotherapy. And really, at that time, I didn't know about Happy Rockefeller and Betty Ford. I learned about, when I was trying to promote my cause, I learned about them later. But my issue with endometriosis, ladies and gentlemen, is more personal. It gets more personal. Because my late father had male breast cancer. And it's such a rare entity. And I did not know about it until he had the cancer late in life. And it was very interesting. Then I learned his father has died not from lung cancer, it was breast cancer he died of. Nobody wants to say the word breast cancer for a man in Turkey. So they used the word, and my father said, in fact, it started as a lump on the breast. My grandmother has always mentioned about it, but they called it as chest. So taboos are not only for women, also for men. So what is endo? Endo is easy to recognize, we think. This is a case that came from Alabama to us. She had robotic surgery. She came with bowel disease. What you see is obvious lesions around. We excised almost 15 specimens from this case. What was interesting on this case is after we did the bowel resection, it went to pathology. And this case came back, as you see, the endo at the bowel, but these are not normal endo specimens. These came as positive for borderline neoplasm. So I am emphasizing the value of excision. The diagnosis has to be made under microscope, not to be confirmed by only visually and ablated. It has to go to a second opinion almost. Somebody else has to read that. And that also, not tissue diagnosis, but also, it's the best treatment. We aim to remove as border-free, and probably not only eliminates the pain and gets the inflammatory tissues out, it also, potentially it may get possible future cancer tissue out. We don't know that. But this article came out in May 11th, original article. My name is there. And I was the one who supplied, out of 24 cases in this article, 17 of them my own cases, and I promoted this article to be published. Unfortunately, I couldn't get anyone in New York to understand what I was doing, so I had to go to Johns Hopkins, and they did it. They sent us a pathologist to Lenox Hill, and she laser dissected these specimens and worked on this mutation foci. So I just want to basically what endometriosis is. Really, endometriosis we describe as gland, stroma, but most important aspect of endometriosis for surgeons, and other surgeons, is the inflammation. What inflammation does, the scarring, and that irreversible damage it causes in the internal organs. It disfigures and finally causes dysfunction of the adjacent organ, as well as immense pain. So this scarring, this inflammation is estrogen dependent. And there are many theories how it really happens, but this is basically most likely displaced, regurgitated, refluxed endomyometrial junction cell complex, as well as obviously it goes with blood and lymph spread to other distant organs. Endometriosis is a difficult disease. It's not what we see. It really is difficult to understand. It infiltrates. It's not really invasive, but it does infiltrate. It goes into lungs, everywhere in the body. So this is a retrograde blood collection. We just do this all the time. My laparoscopy is during period. Always you see blood. But at times, in some patients, you see this inflammation, all these white areas are endo, not only what you see as this black area. The rest are all endo. Those are non-pigmented lesions visually that we call them. So there's another case. We really see, you think you see this, but there's more to see here, obviously. For that reason, visual identification of endometriosis lesions is very important. The color of red, high spectrum colors, really obliterates our visual acuity to differentiate the peritoneal surface abnormality. So I started this. I'm the first one ever did this because I have a patent on this. So I do use diluted blue dye adjuvant to eliminate the retroperitoneal red and white and yellow and try to bring the irregularities of the peritoneum. This is a diseased peritoneum. You don't see any lesion there, but this completely peritoneal surface is destructed. There are holes there, new vessel formations, thickening, and you really can appreciate it when the blue is in the background. These are another vesicular form of endometriosis. Look at this. This is a complete deformed pelvis. Look at that side wall, and look how it looks under the same patient. So you can appreciate the amount of destruction this peritoneum goes. Endometriosis is primarily a disease of the peritoneum. Most of the pain, 99% of the endometriosis is clinically is peritoneal endometriosis. Luckily, probably in the general population, it's not advanced cases we don't see, but we end up operating on the advanced cases. So this is how the peritoneum looks. How you see, I want you to see this thickening here. Oops. Thickening as well as there's glands here you can appreciate. And this is how it looks, the holes from retroperitoneum when you look underneath. So this is how we do it. We just install the hydro distension of the retroperitoneum. You see it, but then it's not. It doesn't stay there. The excision. It doesn't stop with the excision. You have to really dissect the pelvic side wall. You see these obturator vessels here. You can go. We go all the way to the pelvic side wall, the external iliac, obliterated umbilical artery, obturators. This is the uterine artery, the veins, and the ureter is only here. So that meticulousness would be needed in some cases of endometriosis. In many, actually, if you're really going for pain, many patients come back with having had multiple surgeries with persisting pain. Well, it's a disease of inflammation. Anybody can tell what this is? Hands up. Dr. Heyman. This is a stent. This is a rectal stent. This patient's endometriosis is so severe that finally the rectum has given up and the stent has to be put because surgical timing was not made and nobody dared to operate on this patient. This tells us this whole pelvis is frozen. Every organ is attacked by this disease. This is the same patient. Yes, both kidneys are shut up. Pelvic side walls and nerves are rolled, and vagina, everything is involved. When you do endometriosis surgery, it's impossible not to explore the mucosa and the lumen of the adjacent organs. If you can't handle that, don't do it. Let others do it. So very often we are in bladder, very often we are in rectum, very often we have to. Can you play this video? Very often you are in the ureter, you have to resect the endo, you have to put the ureter back. You have to do it. You can't just do it in a second time. Oops. Go back, please. Almost done. So I want to give you a picture of how bad it can get. This is not me. Anyway, so yes, thank you. Can we get going, please? So, I mean, you can see this right ovary with endometrioma, and there's appendix sticking out underneath. That means the bowel is coming there. I mean, it is endless, and it's so challenging. At the end, I have to tell you, for surgeons, it's almost addictive because you want the best outcome, and you really stay in these cases in the OR for hours, all day. And you can't do these cases without other teams around you. And I'm extremely lucky in my hospital. The culture, I believe, has changed. I have people who believes in what we do, what we could accomplish with their help. These cases are handled very appropriately with multi-specialist team. Some of the general surgeons are here who assist me and help me. I assist them in these cases. Our results have been fantastic with bowel surgeries, with ureter surgeries, even thoracic surgeries. This is the same patient, how the really pelvis initially, oh, this is not the same. Okay, this is another patient that you're going to see, this is the pelvis of another patient, but the disease has been really all the way on the diaphragm up there. you can see it is a dual compartment surgery. We had to, simultaneously, we removed the diaphragmatic endo by stapler. It is this right here, yeah. And then she had a bowel disease. We did ileocecal removal of the IC junction with appendix. She had myomectomy. She had actually also pelvic side wall dissection for endo, and we put the bag or everything in that bag with the bowel, and the patient really went home 3 days after her chest tube was removed. What I'm trying to say is there's not a single case I can really do without the help of my co-specialist. In this case, you have to be really aggressive. You have to look beyond this liver. You can't just say, well, there's diaphragm. This patient had chest pain, had all sorts of symptoms suggestive of thoracic endo. So this is, as we lysed this is what we saw. And in this case, it was a quick way out. We basically wanted to prevent future pneumothoraces from this patient. Again, another chest case. You see the implants here. Again, it was done by stapler, thoracically dual compartment. This is how it looked from the inside, the stapling of the total removal of the diaphragm. In some cases, you are tempted when the patient is symptomatic on the diaphragm, you remove this, you end up with a hole. This is my case, but you have to repair it. It's not that difficult. 2 stitches, 3 stitches, it is fine. So overall, we don't know what really causes endometriosis, but the role of obstructive outflow anomalies are definite. And this is a case of a rudimentary horn where the patient came with bilateral endometrioma. And I actually missed this. I did not, because of the intensiveness of the surgery with it, I did not really pay attention to the rudimentary horn. So this is a book chapter in hysteroscopy coming out. We have one or two of my residents, we did this chapter. Our experience with laparoscopically proven endometriosis cases, when you do hysteroscopy, if you're very careful, you're going to see very prominently some midline prominence, corneal funneling, and some variation of arcuate uteri. In our cases, we saw this out of 260 cases, almost 38%. There's one other group also did this kind of study from Connecticut. They called it septate uterus, but there's terminology variation there. I'm going to move a little bit faster here. So basically, you wonder if we have known, if this patient, she is right now 43, but if they had known about this anomaly and had it corrected, maybe one day we'll develop a protocol, if we understand endometriosis as well, or we could be on top of some early anomalies. This patient came up with a spinal iliosacral pin, and operated by the neurosurgeons in my hospital, Lieutenant Hill. And what she had was basically huge nodule retroperitoneal at the iliac spine, and she had stage 4 endometriosis. So, and this is the last case I'm going to show. Interesting case, emergency room admission at Lenox Hill, 60 with hemoperitoneum. You need to know that this patient is 62-year-old, has been getting all sorts of bioidentica from all over, from skin, nose, you name it. And she looked gorgeous. But her cervix was so stenotic. When I looked, there was literally blood all over. And I was curious. You look, this is the peritoneum. It doesn't look that bad, right? That it really looks normal, right? This is what happens. Put the dye back, get that piece, send it to pathology. We pin this like they do in stomach cancer cases. And you see all these endo lesions with peripheral nerves, and we stain this for estrogen positivity. Everything was there in this patient. So we have a great lineup today. I think this is a quote I love. What we observe is in nature is not nature itself, but nature exposed to our method of questioning. So I leave you with this thought. I'm going to invite Carly Goldstein, who is my new associate and fellow. She is going to